Okay, go ahead.
So this was a young female in about her 30s. She had just been treated with methotrexate and DNC, and they were pretty concerned about endometritis. She was coming in with abdominal pain, fever, an elevated beta HCG. They had a very high clinical concern for abdominal infection. So they ended up getting a CT. And already we see in the left adnexa this hypervascular structure here, central area of low attenuation and more peripheral areas of just hypervascularity, peripheral enhancement here. So did anyone have any idea what this may be?
And is it separate from the ovary? I thought I saw an ovary kind of separately, or that is the ovary.
I think this is the ovary here.
Exactly.
And I can show up the coronal here.
CT can be so hard.
Is it the tube, like a tubal ectopic?
Yeah, so this is actually, I thought this was a cool case since we never really see CT ectopic, but this is actually an ectopic pregnancy on CT. And they had prior ultrasounds. This was not a desired pregnancy, and they had such a high clinical concern for infection that they ordered a CT. And so I just thought this was interesting. And this low central area is actually like gestational tissue, whereas more gestational sac, where the more peripheral area is like trophoblastic tissue. And some of the like ultrasound correlates can also have CT correlates as well.
Very interesting. So it's like the ring of fire.
The ring of fire, or the bagel sign too. Yeah, and it's hard because on like if they come in with like hemoperitoneum, it could be a corpus versus an ectopic, but the corpus usually has like a thinner outside, whereas the trophoblastic tissue is what makes it thick and pretty hypervascular.
And do you know if they treated her with methotrexate or that this has to go to surgery?
I think they ended up going to surgery on this one.
Okay. I know like if the beta HCG is too high, like it's too far along, then they can't use methotrexate.
And I think because she had already been treated with methotrexate and failed.
Got it.
Yeah. Okay, then I just have two quick ultrasound cases. So this one we see a pristine thyroid, which in itself is sometimes unusual. But this case, I'll withhold the history here. And we see these oval hypoechoic soft tissue lesions. They're extrathyroidal, posterior aspect. On Doppler, they have a little bit of vascularity, and this was interesting because it was also on the right side, as well as fairly large on the left as well. So I thought this was an adorable case, not our usual thyroid and not really our usual parathyroid adenoma. Does anyone have any idea what a prior history might be on this case? Such as the PTH or?
I was going to say, I would have thought this is in the spectrum of parathyroid adenoma or carcinoma. So I would have checked the PTH and calcium levels.
Yeah, so the PTH, so this was a guy who had had a transplant, a renal transplant about 10 years prior, coming in with elevated, both high PTH, very high calcium. The difference between primary and secondary is the calcium levels. So primary is very elevated PTH, elevated calcium, whereas the secondary PTH would be high PTH but low calcium. So a little bit of an unusual, I thought that these were like parathyroid hyperplasia as opposed to a single parathyroid adenoma. I had just never seen them that large before.
Yeah, that's very cool. And a good review of the, I forgot about primary and secondary.
Yeah, primary, yeah. And that the secondary is typically caused by renal failure. So this was a little unusual since his PTH was both high and his calcium was high as well. So somewhere on that kind of spectrum. But these were just huge. I'd never seen them that large.
Where are they going to treat these?
Yeah, I think he's very symptomatic. So he's on Senecal, that calcium reducer one, that medicine. But I think this was a pre-surgical evaluation.
Cool.
Yeah. And then my final just cute little ultrasound case. This lady was coming in for just viability and dating. And already you see this kind of irregular convex bulge extending from the choriodecidual surface kind of into the gestational sac, a little bit different than our usual subchorionic hemorrhages, which is blood between the chorion and decidua. And then it's important for Doppler on these cases, which showed no internal vascularity. And then just a single month later, it was actually resolved. Does anyone have any guesses as to what this could have been?
Some kind of hematoma that was intraamniotic?
Yeah, so this is, we thought this was a chorionic bump, which is speculated to represent a hematoma. And again, the Doppler with no internal vascularity kind of just representing blood products. It does kind of have a poor prognosis in terms of it increases the likelihood of first trimester pregnancy loss. So you do have to watch them a little bit more carefully. What's interesting is it's not about the size of the bump, but the number of bumps. So women who have multiple chorionic bumps, they are more likely to have a demise than just based on size.
Cool. Do you guys do you do all OB or just first trimester, or what do you?
Just first trimester, and usually if they're coming in through the ER.
Yeah, same with us.
Yeah.
But I have not seen this before. Thank you.
Oh yeah, you're welcome. I've actually seen like 2 in the last 6 months. So yeah, some postulate it's a hematoma on MRI. It'll have a T1 hyperintensity. Some postulate that it's like maybe a demise, a twin demise. I think it's still kind of unclear. I just think it's interesting about, it's not about the size, it's about the actual number. So the multiple chorionic bumps are even worse. Thank you so much.
Thank you, Lindsey, our guest presenter today. Anu, do you want to go? Or do you have?
Sure. Yeah, I found one. I can go. Let's see. Sorry, just one. I think we're okay. Excellent. So this was presented at the tumor board with the history that incidental finding of multiple liver lesions, relatively young person, no known history of underlying liver disease. This is what the T2 fat sat looks like. And as you can see, you know, there is some breath hold issue here. They're breathing a little bit through the exam, but you can see multiple T2 hyperintense lesions throughout the liver. And I'm going to show you the pre-contrast T1 as well. I'm just going to pull it down. Okay. Oops. The pre-contrast is right here. These are dark on pre-contrast T1. And then I'm going to show you the post-contrast images. I'll make sure I don't have any PHI as I move around. Okay. So moving on to the arterial phase, this is what the arterial phase looks like. I'm going to scroll slowly and let you see all the findings, lots of findings here. You know, there's already enhancement of the portal vein, but interestingly, there are a lot of what look like intrahepatic shunts. There are too many vessels in this liver, let's put it that way. And then the lesions themselves do not enhance very brightly on the initial phase. I'm going to scroll through all these and let me show you. Sorry, I just pulled this case up, so I'm a little sloppy today. I beg your pardon. And then on the subsequent phase as well, here is the venous phase. You can see the hepatic veins opacified, but lots of vascular channels in the liver, right? And then you can see these lesions here. So I kept this at the back of my mind. He did have, these are just healing fractures. The spleen looks a little big. He didn't have ascites. And then I went into the priors, the remotes. And so I'm going to show you a liver MRI that they had back in 2013. And this is what it looked like back in 2013. So here is the T2. These lesions were much bigger in the liver. This is the pre-contrast T1. Some of them actually were bright on pre-contrast T1. You can see the pancreas here is intrinsically very bright on T1 pre, and these lesions are bright too. And then moving on to the later phase, they all enhance. There is still a lot of action going on in terms of the vessels in the liver. And then I'm going to show you the hepatobiliary. So they had an EOVIST scan back in 2013, and all these lesions retain EOVIST, the hepatobiliary agent, fairly uniformly. You know, this one you might argue there is a central scar. So multiple lesions, no known hepatitis panel positive, no other underlying known chronic liver disease. This is 2013, and then the more recent one I showed you, that these lesions are much smaller in size, and the intrahepatic shunts have increased in amount. There are new subcutaneous collaterals. We don't have any imaging in between. Any thoughts? The liver, you know.
One thought for the liver vascularity, I was thinking about HHT, Osler-Weber-Rendu, and I think Gitanjali showed a few cases of that, and the hepatic artery gets really big, and this hepatic artery looks huge.
Yep.
And so then I was thinking, in the setting of a vascular abnormality and congestion, you can get large regenerative nodules that are FNH-like.
Exactly. That's exactly what I told my team. So we don't have proof of anything here, because, you know, they'll just be followed up. But that's exactly what I think is happening here. They're presenting after many days, many years, nothing in between. And have you seen those regenerative nodules grow smaller? Because the shunts seem like they've increased in size and quantity, whereas the regenerative nodules are smaller. So that fact I thought was very interesting in this case. Have you seen, I mean, I don't know what their course is over a period of years, what happens to these regenerative nodules. So
I've actually seen them getting bigger in patients. Like, we have a large Fontan population, and you know, congestive hepatopathy, and then we see a lot of these, and you know, larger LRN, large regenerative nodules, and you want to make sure you don't use LIRADs, and you make sure you don't call them dysplastic nodules or HCC. But I have seen cases where they've kind of slowly gotten larger. But I could imagine that, like, yeah, if there's all this change in the vascularity and the congestion of the liver, that like just the regeneration itself is constantly changing. Yeah.
So yeah, exactly. I mean, I thought that fact interesting, that these have regressed in size actually. And these do not have malignant potential. So that's the beauty of it. So, you know, no biopsy necessary. And I don't know in terms of systemic therapy, what they might offer him, I guess based on symptoms. I forget what he presented with and why he had this repeat MR after many years. But I thought it was interesting that these are smaller now. All right. So I'm going to stop here.
Anu, does he have a known diagnosis of HHT?
He doesn't.
Okay.
He doesn't. Now he might. We've sent them on that route, so he might. Okay. That's it for now. Yeah.
Victoria, you want to go?
Can you hear? I kept saying sure, and then of course nobody can hear me. Let's see, advanced. portion of screen. All right, this is not the case that I'm going to show. So I have a few cases, and we can start with this fascinating case that happened not that long ago. So can you see what I'm showing?
Yes.
Yes.
Okay. Is that so? Anyway, so any thoughts? And full disclosure, I saw the plain film after I saw the CT, so I don't know how I would have interpreted it. I would like to think that I would have gotten the right diagnosis, but I may not have. So, any thoughts? And I can do this in case like this is easier. I'll just zoom in. I don't know. This may or may not help. Any thoughts?
Two thoughts.
Go.
One thought is possibly sigmoid volvulus with an upstream bowel obstruction, and the other is I see a Wriggler sign and air over the liver, so perforation.
All right, so that's why Aarti is Aarti. So I'm gonna keep like telling myself that I may have picked up on the Wriggler sign, but I'm gonna hope that I would have. But the thing is, I started with the CT because they, as you know, I assume that happens in other places as well, that they got both at the same time. And you can see that there's just huge amount of free air. This patient had recent takedown of sigmoid, of the descending colostomy. So you can see that there's quite a bit of free air. The surgery was like within a few days, maybe 4 or 5 days. But this is just a lot of free air unless the patient had, laparoscopic surgery, which we could not get this diagnosis. So, so there's a lot of free air, which we kind of thought that probably doesn't look like it's related to just surgery. So then you can see that as you follow the colon, this is not sigmoid volvulus, right? Like if you come back here, this is the rectus sigmoid, and everything is collapsed as you move up. So this was the anastomosis right there, and coronal showed it better. On coronals, you can see that the abrupt caliber change happened at anastomosis. So now we were, there's free air, and then we kind of looked through it, and we decided that we can't really identify the site of perforation, although we suspect that there is some, and this is high-grade obstruction at the anastomosis site. And as I'm about to, finish the case, this catches my eye right here. So the cecum is dilated, and the question is this just a little bit of stool, trapped or not, right? And so went back and forth, and then decided, this is, you don't have this anywhere else, right? It's not like you have, bowls of stool, kind of, in which case sometimes it's difficult. So we decided we're going to call it pneumatosis. Called the team, and patient was just being ruled out from surgery. So I guess patient wasn't doing very well. So they just took it to surgery without even talking to us about the finding on CT. So what they found on surgery was indeed an obstruction at the level of anastomosis, a lot of free air, and focal perforation at the level of cecum. So that was pretty cool.
Yeah, and actually that's like the Laplace law thing, right? Like the cecum is the one that will perforate because they can't take it. And when you have a large bowel obstruction, that's like the site.
Right. But you could, it's very subtle. It's not like this massive, thing.
Yeah, I was actually wondering if it was going to be not the colon at all, because usually if your colon has this much stool in it, then you're going to have more like fluid and stool in the abdomen in addition to the air. And so the fact that this was only air, I was thinking, oh, it's going to be like the stomach or something like something unrelated.
But no, that's, and yes, that was yes, it's very unusual to have this degree of free air with colonic perforation. I've seen this degree of air with like ulcers, is the same thing as what you said, Aarti, but can't argue with with what they saw. So that was a cool case. So the next cool case is this person. it's more of a sad case than cool case. This is a young woman or man. I'm not sure. I don't remember if it was it was a young person in early 40s. I think maybe even 40. And this is a late August study, and you can see that there's a little bit of kind of there's a lesion here in the pancreas, and then you have multiple metastases. So this was metastatic pancreatic cancer back in. So this is 2 months prior. It's more like closer to 7 weeks prior. So patients' LFTs are elevated, so come back for extra stuff, workup. And now you can see that the liver is just riddled with cancer. You can see it on restricted diffusion. They will restrict. And the reason I'm showing this case is that the trainee with whom I was reading was kind of in disbelief that the cancer would progress this rapidly. And sometimes it happens. There was also, hold on. You can also see that there are necrotic nodes. And what's unusual about this patient is that you can see actually metastases, and this is pancreatic cancer. So, you can see that some of these metastases actually in the subcutaneous tissues right there, just not a usual behavior of pancreatic cancer. Another interesting thing in this case is that you can see here, this met just burrowed through the capsule and invaded the colon. There are several other metastases. You can see they burrowed through the capsule and then invaded. So this is a super aggressive tumor. You can see here little peritoneal implants. So unfortunately, cancers can progress very quickly. I've seen cancers progress in 2 weeks' time. We always think that, if something progresses that rapidly, cancer kind of goes down a differential. And it's true, but it doesn't exclude cancer. The cancers can grow quite rapidly, especially when they're aggressive in young people. So just a little tidbit. You can see another peritoneal implant here. Aarti, comments?
No comment, sad. But it is interesting how small the tail tumor is too. So sometimes pancreatic cancer, the primary tumor is not even that big, and then
there was here. This is so that's a great point. And sometimes we can't see the primary at all. And there's a large autopsy series from 70s, I want to say, but don't quote me on that. So it's an old autopsy series, but large one with patients with pancreatic cancer. And there are some that widely metastatic disease and the primary is less than a centimeter. And there are a few with widely metastatic disease where the primary, even on autopsy, is not identified. So,
wow,
it can happen. All right. So the next interesting case is it is more of a fascinating case of, hold on. Okay, so you can see, hold on, I should have, this is a little bit, just grab the T2s. Sorry. Come on, computer, walk with me here. Okay, so you can see there's a big thing here, very large, very heterogeneous, kind of almost strange looking. And, when we look at the, contrast, it looks pretty classic, peripheral nodular discontinued enhancement. And this is the most delayed images. And you can see that the enhancing components enlarge and coalesce. So this is just a very large, kind of weird hemangioma, which if we look at study done 90 or so, like 6-7 years ago, you can see it kind of looked a little less unusual. So this is, like our, sclerosing hemangioma situation. What's cool about this case, what I wanted to show is that we have elastography because they wanted to do the, to assess the liver up front. So you can see that on top, elastography values, the stiffness values of the liver are pretty normal, like 2.2, 2.3 range. When we go, again, 2.4, 2.1, we go to the area of this hemangioma, and now you can see that the stiffness goes up considerably to like 4.8 range, which makes sense, right? Because if this hemangioma has a lot of fibrosis, it makes a lot of sense that its stiffness values are higher, right? Because if you think about your typical hemangioma, it's usually just kind of collection of blood vessels, so it should be fairly soft. But this one is not. It has a lot of fibrotic tissue. So it was cute that we actually have elastography to prove that this hemangioma has a lot of fibrotic tissue. That was just a cute case of that.
Yeah, I have two comments. One is that's interesting. It got bigger because normally sclerosing hemangiomas get smaller as they fibrose down, and they can even have like capsular retraction stuff. So it's interesting. Right. This one's almost like proliferating fibrous tissue or something. And then my other question is, I've never really thought about using elastography to help you with the diagnosis of a lesion. Do you know anyone who's done that? Like for example, you could use it to say like a cholangio is fibrotic, or might be more, have more stiffness.
I think there are some papers that attempted to look at stiffness, and they're looking at more of like, I've seen papers looking at predictive values. But this is all just, I don't think anybody uses that in a clinical setting. I mean, when I saw this case, I texted people around, and nobody has a case where they have stiffness of a lesion. You're right that these usually decrease in size, but I don't think I guess it is kind of, does look like it kind of, part of it is increased. But it's not the entire thing is fibrosed, because you look at it like a bunch of stuff is still enhancing. So it is a funky looking lesion, but still hemangioma. So.
Yeah, so there's two different terms. One is sclerosing and one is sclerosed. So when it's on its way, we call it sclerosing. And that's when you still see those nodular areas of enhancement. And then when it's completely kind of fibrotic, then it's sclerosed.
Right. And this is it. Here, I'll extend it. Actually, this is 161 months prior. So that would be like in July of 2008. So that how many years? 12 years? I can't even count anymore. 13 years. So you can see that it has increased in size, but it's not. It's just a funky hemangioma with sclerosing components. Anyway, so I thought that the elastography here just really makes the case very interesting. And my last case, let's see, just have to figure out which case I already showed this one. I think this is the case. Now this case I sort of need your input on, because I don't think I've ever seen this situation before. So I'm going to hide all the annotations. So this patient had a complex surgical history. Let me just do this and zoom in. You can see, had a surgery. She had colectomy for, okay, I don't remember for what, but some diverticulitis, I think, diverticulitis. And check this out.
Whoa.
So I've never seen this before. So maybe Aarti, have you ever seen this complication before? I don't quite understand how that happened, but you can see that there's myometrial basically infarction here. You can see that this is the uterus, and it's just the entire left horn of the myometrium is completely necrosed, and I don't quite.
Yeah, would it be considered like a uterine perforation?
Yeah, is that an open defect? I was going to say.
Yeah, like
the thing is, it wasn't myometry. It was just your routine. Hold on, let me just get. This was the prior from like a couple days before. So this is what it was. Patient had, you can see, had a diverticulitis. There was a leak here.
I wonder if that diverticulitis was already kind of making a fistula with the endometrium.
Interesting. Oh, yes. So wait. So let me pick up another one. So this is the original CT with which she. Oh well, this one is pneumatosis. Yeah, maybe not even. So this is what she came in with. We don't have anything before that, and not sure that there was any involvement. Although, who knows? So I've never seen myometrial necrosis as a complication of colonic surgery. And I was not sure how to tie it in together. Here's the coronal from before she was surgerized. You can see that this aspect of myometrium kind of looks normal. There was, an abscess here, like in the like in the space between the bladder and the uterus.
I have seen diverticulitis fistulized with a uterus.
Right, I've seen that, but it seems that this was post-surgical complication. They put a bunch of drains in. Anyway, so I don't know. Isn't that weird? And it almost looks like she didn't have that endometrial. Her endometrium wasn't thick, and so I think that she must have some sort of communication between all this peritoneum and endometrial cavity, and it's just filled with pus. But I can't prove it to anybody. But that's my thought on the matter. Any thoughts about that? See that?
No, I think that it does look like endometritis. I think it's perforated. It may have, I don't know. I guess there's two possibilities. Like one, it could have been from the diverticulitis, could have been maybe an injury, like a little retractor injury during surgery, or, like that caused the laceration.
Right. And this is the follow-up, which I actually haven't seen. This is the follow-up from a few days later, it seems like. Here's the follow-up from 10 days later. I don't think anything changed. We still have a hole. It still communicates with all this. Yeah. Anyways, it was just a wild, thing to see this.
Yeah, that's a lot of inflammation down there.
Yeah. But somehow there's this.
And it's like almost also communicating through the abdominal wall. It's like fluid layering over there. Yeah.
Yeah, no, she's not necessarily doing as well as I would hope she would be doing. Okay, so these were my cool cases for today.
Cool. We also have a new presenter, Flo, from Mount Sinai West, told me she has 1 or 2 cases.
Hi, everybody. It was great seeing you guys in person at Sabi. But I think I've got a case. I didn't really prepare them. I just kind of jumped in. So let me just share my screen and hopefully not share anything important. Let me make sure I can anonymize properly. Is everyone seeing my screen now?
Yes, looks good.
Okay, perfect. So this is a 49-year-old female, initially coming in for a little bit of weight loss, and just concerns for some abdominal pain. So you can kind of see there's arrow signs everywhere, and there's just some adenopathy. And if you keep scrolling down, you'll see these lesions in the pelvis region. Does anyone have any? There's no MR, unfortunately. This is just abdomen pelvis. Anyone have any thoughts on potentially what this could be?
I actually have a companion case for today that looks very similar to this. So
Okay.
I'll let other people contribute first. What do you guys think?
So these look like enlarged ovaries to me. Do you see her ovaries separately from these?
Right. So these are, they are enlarged ovaries.
But the position of the right ovary bothers me. It's like posterior is stuck to the posterior wall of the uterus. You know, I always think of endometriosis when that happens, even if it is one ovary and not like kissing ovaries.
Right. So it just so happened that she ended up getting an endoscopy because of her abdominal pain. It was bothering her enough. She was found to have gastric cancer. And so they went in to biopsy these ovaries, and it turns out these were bilateral Krukenberg tumors.
Cool.
Yeah, but otherwise, that was exactly, like, at first I was like, these are just enlarged, thinking of endometriosis or something, but they never actually went up with an MR, but it was because of, I think, her complaints, and it just turned out to be a weird case.
Wait, Flo, can you show us her stomach again? Like, in retrospect, can we see the cancer?
Yeah, that's what I was concerned about, and I was like, I don't really, other than that lymph node that was hanging out, and it's not even that enlarged, honestly, right? Like 0.9 centimeters is kind of borderline. I'm guessing it doesn't really have a reniform shape, so maybe. And I think that was actually added on after they went back to ask if we had seen anything, and that's when we measured that lymph node. But I don't think that this could have been prospectively called.
Yeah, almost like her whole proximal stomach looks a little featureless, like along the greater curvature and stuff. But yeah, and even the lesser curvature right there. But I would definitely probably not have called that prospectively. So it's kind of scary how much we miss gastric cancer.
Right.
Stomach is scary, but this is not callable. Otherwise, we're gonna have to call it on every person.
Yeah.
Right.
Yeah, but it's scary that she already has ovarian mets. But I do think, and in general, it sounds like a good teaching point from this case would be like, if you do see bilateral ovarian masses, always check like the stomach, the pancreas.
I find that I use the iodine sequences. I don't know if you guys do the dual energy, but sometimes I've picked up like a small gastric or a pancreatic just from the iodine sequences.
Oh, I did not know. We don't use iodine here, so I wouldn't actually quite know how to interpret that if we were to share it. Hopefully, I get that in fellowship. So this is a 37-year-old. I'm going to withhold history for now, but does anyone see anything in particular? This is probably the image that was the diagnosis. It's a very straightforward case.
Did this patient had prior cesarean section?
Yes.
Dehiscence of the scar.
Yes, and there's a name for that I learned recently. It's a uterine niche, and so you have basically a defect where you have a collection of blood that forms, and they do need to go in and repair this because otherwise you could have rupture. And this person ended up getting it repaired, and I will just go. And you'll see that afterwards there's a very thinned out portion where the uterine niche was, and the GYN asked us to measure that thickness because the patient still wanted to be pregnant another time. That's it.
Cool.
Very straightforward.
Thank you.
Thank you.
Okay, I have a few cases. Okay. Whoops. First one is actually a nice companion to the one Flo just showed. So this patient had multiple fibroids. This is their uterus. They had large, like exophytic fibroids. Multiple exophytic fibroids. This is the uterus. And then I just want to draw your attention to these, which were the ovaries.
Oh, this looks much more like what the other speaker had mentioned about the possible tethering.
They're very dark though. What do they look like on other sequences, Aarti?
Okay, this is, let's see, I'll show you on the FATSAT. Here they are. Exactly, they look very, very dark. Pre here. And they basically had progressive enhancement. And you can see that the fibroids are enhancing quite a bit. These ovaries are not enhancing as much, but they do have kind of slow progressive enhancement.
Yeah.
And so this is the final sequence here.
I forget the name of this entity, but this is some sort of fibrosis of, what is that called? Yeah.
Yes, so my colleague Melina got it for me, and she sent me this article. And basically it's ovarian stromal hyperplasia or ovarian hyperthecosis. These were actually our friend Liz, this is her paper. And so at NYU, they went through all of their path-proven cases. They had 27 patients who had path-proven ovarian stromal hyperplasia, and 2 of them had MRIs. And basically what they said was on MRI, if you have enlarged ovaries that are T2 dark, it can cause this ovarian stromal hyperplasia / thecosis. And they tend to have like some kind of slow delayed enhancement. You should not mistake them for fibromas or other masses. And the interesting thing is that they often will produce androgens, and these patients can present with obesity, diabetes, hirsutism. And so it is an important thing to sort of not say we're concerned about these ovarian masses, but they will do a workup and see if they're having any hormonal issues, and then they can treat them with gonadotropin releasing hormone therapy. So this patient actually is pre-diabetic, and so I don't know if it's related to this. They didn't have the other symptoms, but I just thought it was really cool. So thank you, Melina, for helping me. And then another interesting thing is that there is one more thing in the differential that's called ovarian fibromatosis. And that is something that gives you this black garland appearance. So in ovarian fibromatosis, you get fibrosis, but you also get like these preserved follicles, and the stroma is also preserved. So it looks like a black garland along the rim of the ovary. So that's one way to tell the difference between fibromatosis versus this one, which is stromal hyperplasia.
So because it's so dark and you're thinking it's more of a fibrotic process, would you be okay not biopsying and just 100% being confident about it?
I think so. That was the point of Andrew's article, was that we should be familiar with this entity. We should bring it up so that they don't necessarily resect it. They treat it medically.
Got it. Thanks.
Yeah. I mean, technically, if these were bilateral fibromas, those are benign lesions too. And like individually, each of these would have been an ORADS 2 lesion. So they might not have resected it anyway, but we were just kind of like intrigued, like, what is this? What's going on? And if you bring it up, then you could possibly like test their androgens and stuff. Okay, this is my next one. So this patient was undergoing IVF. We see some findings already. So pleural effusion, some ascites. What do you guys think about the ovaries? Somebody's chatting. Oh, Victoria is leaving. Anyone have any thoughts about the ovaries? None?
It almost looks like Cecal cysts, but they're not. They're too like ectophytic looking.
Yeah, so this actually was ovarian hyperstimulation syndrome. And they can look like, I think it's just, I agree, it looks strange. It looks different than a lot of the ones in the literature where like the entire ovary is enlarged. And then you have like, it looks like cysts are contained within the ovary. But this one, I think they were just kind of like bursting out. So they ended up stopping her IVF cycle, and they did not end up doing the egg harvesting. So ovarian hyperstimulation, basically the ovary starts secreting hormones that cause leaky capillaries, and that's why you get the ascites and the effusion. It can lead to hypovolemic shock. It can also lead to torsion. Okay, this is my.
Do you ever have it again, or this is kind of more of an OB question? I'm just curious, or do they have to like never do it again?
there are certain things that make you at risk for ovarian hyperstimulation. So here, actually, this is the Radiopedia article on it. But if you already have like a large ovary or you have polycystic ovaries, there's certain risk factors for it. So I think in those patients, maybe they would, if they're going to do IVF again, or they're going to stimulate them again, they might change the meds they put them on, put it on like a lower stimulation cycle. But I don't know if they're like, it's a contraindication in the future.
I love your ovarian theme of today.
I do have, actually I have one more, but this is not ovarian. So what do you guys think about this patient's abdomen here?
Is that like a large duodenal diverticulum, or what is that exactly? Oh, or maybe it's just.
Yeah, so we were confused. We were wondering, like, what is this thing here? There's a lot of stranding also. So there was some concern, like, is this jejunal diverticulum? Is there a diverticulum, or is it like expansile? Like, it almost looks like the lumen is going into this. So is there expansion of the jejunal lumen? Is this lymphoma? Is this some kind of pancreatitis that is also affecting the jejunum, since there's so much stranding near it? So anyway, the patient ended up getting an MRI. This is what it looked like on MRI. So it's like really T2 bright. And this looks to me like almost like a tubulovillous adenoma, like a really polypoid large mass. You can see it here. So we see it much better on this MRI than on the CT. And it does look like it's sort of like growing along the lumen. And then the other cool thing is we did a fluoro study, and you could actually see a big filling defect in the jejunum here. So they went with small bowel enteroscopy and they biopsied this. I thought it might be like a huge tubulovillous adenoma. The path came back invasive adenocarcinoma. So it could be adenocarcinoma that arose in a tubulovillous adenoma. The larger these adenomas are, the more likely they are to have invasive adeno in it. And basically you have to resect them. Any duodenal or jejunal adenoma, you have to resect them once they get over like 2 to 3 centimeters, because they almost certainly will have adenocarcinoma even if you don't get it on biopsy. So just an interesting case. We don't know why it was so inflamed, why there was so much stranding around it, but this thing is a big cancer, probably arising in an adenoma. And when I've seen these large adenomas like this, sometimes patients have like Peutz-Jeghers syndrome. This patient does not have that. So. Okay, and then this is my last case. So the patient was pregnant and had right lower quadrant pain. You can see the pregnancy. We're getting some dielectric effect here. So cephalic position, anterior placenta. And anyone see anything else? I'll window it.
She has some dilated small bowel loops, is it?
Yes, exactly. So other things we want to exclude, there's no hydronephrosis. Her gallbladder looks decompressed here. I don't think we saw her appendix, but the main finding is that she's got dilated small bowel. And there was a transition, there's fecalization in the small bowel here, and then there's a transition point right here. So basically the pregnancy had caused this sort of eventration of her entire abdominal wall. We were sort of debating, like, is there an actual hernia, like fascial defect here, or did it just get stuck between like the eventurated abdominal wall and this musculature over here, like basically her rib cage? But so this was a small bowel obstruction with the transition point right here. They ended up treating her conservatively, and actually it resolved once they put an NG tube down and kind of like decompress the small bowel. And they were just going to wait for delivery and then like explore at that time.
Super cool.
Yeah. So there's our fecalized bowel and then transition.
In the coronal plane, it almost looks like a closed loop, like an inverted, it looks like there are two transition points.
Mm-hmm. Yeah, it's sort of like peters out because she was vomiting a lot. So her proximal small bowel is definitely petered out, but okay, that's it for me. Thank you to our new presenters. I'd love to have you back. And that's it. And actually, can you stand for 1 second? I'm going to stop the recording.